Hello, everyone. Welcome to the Gout Support Group of America's webinar this evening. My name is Stephanie Hugh, and I'd like to start by thanking our panelists and participants for joining us today as we discuss gout treatment and clinical trials. Over the next hour, we will learn valuable information that could positively affect your gout journey. We will also have time for Q&A, so please make sure to submit your questions in the Q&A box. Or if you're watching our Facebook Live, please submit your questions in the comments section. Before we get started, I'd like to introduce our speakers for tonight, GSGA's co-founders, Dr. Chris Parker and Gary Ho, as well as our two guests from the TRUST trial, Dr. Michael Berry and Dr. Hyun Choi. I'll let each of them tell you a little bit about themselves. Dr. Parker, I'll hand it to you first.
Sure. Thank you guys for listening in. We'll try to bring you a lot of great information again tonight, like usual. I'm a community-based rheumatologist out of Austin, Texas. Developed my interest in gout back when I was at Walter Reed in the 1900s and have been remained interested ever since.
Great. And I'll jump in right now. I'm Gary Ho, the other half of the Gout Support Group of America. So as many of you know, most likely, I've lived with gout since 1994. We started the Gout Support Group of America just because as I was going through my journey, it took a very long time for me to receive a diagnosis. Doing some reflection, the 16 years was just really dark, right? And there was not a lot of support, not a lot of good information. And that is the purpose of the Gout Support Group of America. So that's when Chris and I decided to launch this group really in his office in 2015. There was like, 5 couples, right? And I tell the story of wives dragging their husbands to that morning meeting. And I think they looked pretty grumpy at the time, but we did give them some donuts and some coffee, and we talked all things gout, and it was just so amazing. And so the birth of GSGA. So here we are, and tonight I'm just very excited. We have 2 special guests, and I will go ahead and turn it over, and they will introduce themselves, and then Stephanie will take us away.
Maybe I'll start. I'm Dr. Michael Berry. I practice general internal medicine, and I've practiced adult primary care here at Mass General Hospital in Boston for, I'm afraid, 40 years, and taken care of many people with gout. Have participated in many guideline groups, including the American College of Physicians and the U.S. Preventive Services Task Force. And it's been a pleasure to team up with my rheumatologic colleagues to design and now conduct the TRUST trial to see if we can get to optimal gout management. Hyun, over to you.
Yes, thank you. My name is Hyun Choi. I'm a rheumatologist, a colleague of Dr. Berry at Massachusetts General Hospital, and a professor at Harvard Medical School. I'm a co-PI of the TRUST trial that Dr. Berry described just now.
Wonderful.
Well, discussion, yeah.
Wonderful. Well, thank you all for being here. We're excited to jump into the discussion. So as we know, gout is the most common inflammatory arthritis and can substantially decrease quality of life and function. Even though it's common, optimal management is not well understood. That's why today we're going to focus on the TRUST trial, a multi-site clinical trial funded by the NIH to compare common treatment strategies for gout. So Dr. Parker, for those who may be unfamiliar, can you explain what a clinical trial is?
Sure. So I'm going to perhaps oversimplify, but the nuts and bolts of it are if doctors or researchers or a combination thereof have a particular question that they need answered in humans, they'll organize a trial to answer that question. It's very important when you're doing that. There's so many variables out there to really try to not have only one variable that we're looking at and compare to one other thing so we know what's happening. Sometimes that means a medicine or a supplement is compared to a placebo. Sometimes that means a new medicine is compared to one that has been around a long while to see if it's better, worse, or same. And naturally, when we're doing that, we want to see not only is it better, but is how safe is it, right? So every single thing that a patient might complain of will be written down and quantitated. So at the end, we can compile all that information and really answer that all important question. Is this medicine or supplement or therapy better, worse, or same? And if it's a medicine, is it safer or less safe than the current therapies we have?
Wonderful, thank you. And is there anything you would like to add on why this is especially important for gout patients?
Well, I'll let each of the people weigh in on that as I see it. And as Gary mentioned earlier, even though doctors have known about gout probably all the way back since Hippocrates 1800 years ago, and I think there's documentation of that in the literature, even with all that knowledge, there's still a lot we do not know. And that's ultimately why this trial and many trials after this one going forward, we're going to be answering questions to, as the other doctors have shared, trying to get us to optimal therapy as safely and quickly as possible.
Thank you. And Gary, as a gout patient with experience in a clinical trial, can you talk about your experience? Why did you decide to participate, and what was your main takeaway from your experience?
Thank you, Stephanie. Yes, thinking about clinical trials, this is personal for me. I, in fact, went through a clinical trial in 2010. That's part of my story. It's part of my journey. Again, it took 16 years to receive a diagnosis, and during the 16 years, I had to really try to manage my gout with over-the-counter medication, right? So and it wasn't that great. So I would almost categorize myself as being unmanaged for those 16 years. And if you know anything about gout, when you leave it unmanaged, it actually becomes pretty devastating for the body. So I had developed tophus, basically knots, right? If you can imagine them, knots that form when your uric acid level is too high for too long. It actually turns into little crystals around the joints. And so when I was diagnosed, my uric acid level was above 10. I had some knots within my body. And Chris, we tackled it right away. And I was taking some medication to try and lower that uric acid level. But in my case, because I've gone untreated for so long, it would have taken probably a few years, we guess, in order to get my levels low enough so that my body can start to repair itself, right? And so this is where the clinical trial came in for me. In 2010, Chris approached me. He was part of this, this clinic, this trial. And he says, Gary, you might be a great candidate for this medicine. It's a new medicine. It's a drip therapy. You're going to have to come into my office. I'm going to have to see you once every 2 weeks. And it's going to be a long time. It's going to be 6 hours per treatment, Gary. But if I look at it, it could be a life changer for you. And I contemplated the pros and cons, and I thought, man, nothing can be worse than where I'm at right now. So let's try something new. And then I went ahead and participated in the trial. Going through the trial, it gave me access to medication I would not have had, first and foremost. Secondly, it gave me access to physicians that are not just knowledgeable, but top physicians when it comes to gout treatment. So I understood that I had top care, right? And then just the hope that my gout can be managed and that I can live pain-free was enough for me. And so, going through that clinical trial process for me, it was 9 months and it was great. I mean, I can basically look back and say I was part of something amazing because being in that trial, I along with others that went through the trial, were the forefronts of those living with unmanaged gout, and we were able to prove that this medication, this strategy, this new way of managing gout was successful. And by the way, it's FDA approved since then, and thousands of people have gone through this treatment because people like myself dared to take that first step and to believe something, I think, bigger than ourselves, right? So that's a little insight on my feelings on clinical trial. I'm pretty passionate about clinical trial.
As you should be.
Yes.
Well, thank you for being so open about your experience. It's very important. And thank you to Dr. Parker for introducing Gary to the clinical trial. Dr. Berry, let's turn to you now. There's a new clinical trial you are involved with called the TRUST trial. Can we start with the basics? What is the TRUST trial? Who is managing this trial? And what does it hope to accomplish?
Sure, and I will show a few slides, very few, because I see we already have questions pouring in. So we want to get to those questions quickly. And but a little bit of introduction of this clinical trial. And again, thanks to Chris and Gary for both forming this important group and recognizing the importance of studying important questions through trials. And this is the TRUST trial, or Treat to Target Serum Urate versus Treat to Avoid Symptoms in Gout, a randomized trial. You see the three principal investigators here. I represent primary care. My colleagues, Dr. Solomon and Dr. Choi, represent rheumatology. It's a great collaborative trial. Much of gout is managed in primary care, and we need to bring additional expertise, in my opinion, to primary care. We're doing this trial currently at 7 sites, Mass General and Brigham and Women's Hospital, which are coming together as Mass General Brigham, Boston Medical Center, which is part of Boston University, the University of Alabama at Birmingham, NYU in New York City, UCLA in Los Angeles, and our newest addition is the University of West Virginia, bringing more patients from rural areas who often are unrepresented in trials. And I know you're going to look at this and say, boy, there's no gray hair there. That looks a little bit different. And I can tell from the pink shirt that this is probably a Miami Vice era photo, but I love it. And it's nice to do without the gray hair occasionally. So let's see. So I really don't need to tell this group that gout is common and affects more than 12 million Americans. It's now become the most common cause of arthritis visits to emergency departments. That used to be rheumatoid arthritis, but there have been new approaches to control rheumatoid arthritis. And as the incidence of gout has gone up for reasons we'll get to, that's really the main cause of arthritis visits to ERs. And again, 90% of gout care occurs in primary care. So this is a trial we're actually doing in the primary care environment. And there's, despite, as we heard from Chris, hundreds and hundreds of years of experience with treating gout, there's still a lack of agreement about the value of achieving a target serum urate level, at least for many patients. So rheumatology guidelines emphasize a treat to target serum urate response, but often in primary care, the focus is on treating to avoid symptoms, to minimize symptoms, to treat symptoms early. And even in using urate lowering therapy, perhaps not focusing so much on the uric acid level, but on the patient's symptoms and how they're doing. And the TRUST trial will address the lack of evidence comparing these different strategies by collaborating between primary care clinicians and rheumatologists. And this is a trial of 2 different strategies of gout management: the focus on uric acid, treating to get to the target, focus on the symptoms, focus on how the patient's doing. Now, everybody cares how the patient is doing, but the difference is the target serum uric acid approach. We've interestingly learned as we go through our electronic records, for example, at my hospital, there are literally hundreds, probably thousands of patients in our primary care practice who are already following the treat to avoid symptoms approach. Some of them may be undertreated if they're particularly suffering from frequent attacks. And again, those are the groups of people we want to find an answer for. And we may find that for some people, one treatment is better, and other people, the other approach is better. And time will tell when we get our study results. So again, we're comparing patient-centered gout outcomes of two commonly used management strategies. We abbreviate that treat to target serum urate as TTT-SU and treat to avoid symptoms as TTA-XSX. The primary outcome that we're measuring in the study is the rate of gout flares across the two treatment arms. But we're also measuring patient quality of life, which can certainly be affected by gout and particularly recurrent gout. And then there are sub-studies looking at issues like control of blood sugar, glycemic control, blood pressure control, and kidney function. My rheumatologic colleagues think there may be some value in these domains of keeping the uric acid low, but that's really never been tested well, and we're tackling that as well. To get into the trial, the inclusion criteria, as we call them in a trial, are relatively straightforward. You have to be diagnosed with gout, and we review that diagnosis when people enter the trial. You have to have at least one gout flare in the previous 12 months. You have to have a baseline serum uric acid level greater than 6. Below 6 is generally the target that's used. So if someone's already at the target, then they wouldn't be a candidate for the trial. And we're certainly not advocating that people back off from their successful therapy to join the trial. It's the people who aren't there yet we're interested in. And of course, for any clinical trial, patients need to understand the pros and cons of being in the trial and sign an informed consent to join us. There are some exclusion criteria, probably the two most important of which is if they're already on more than 200 milligrams a day of allopurinol, the primary urate lowering therapy that is used these days, they're not eligible for the trial. In other words, if they're already well on their way to a treat to target approach, they wouldn't include them, but up to 200 milligrams a day is included. And many of my rheumatology colleagues think that's under treatment, at least in terms of getting it to the target serum uric acid level, but not true for everyone. And then the other main exclusion is chronic kidney disease, which complicates the use of some of the medications. There are some other rare exclusions that we don't run into very often. Heaven forbid someone has gout during pregnancy, which can happen, but that wouldn't be a participant for this trial. Okay, so all patients in the trial are managed by specially trained nurses with backup from our study investigators, both primary care clinicians familiar with gout and our rheumatology colleagues. All subjects receive education about the pathogenesis of gout and personalized advice to reduce known risk factors and comorbidities of gout. In the treat to target serum uric acid level, our first choice is allopurinol. If they can't tolerate that, there's a backup medication, febuxostat, which is relatively new but quite effective. And the goal is to lower their serum urate to less than 6. They take, in that arm, daily prophylactic medicines to prevent flares while their serum uric acid level is being lowered, mostly colchicine. One downside of lowering the uric acid level is sometimes you can trigger gout flares as the uric acid is being drawn out of the body and out of the joints in particular. So we use a preventive medicine to try to prevent those flare-ups. They'll also be given medications, obviously, to treat any flares that may arise. And lifestyle and diet education and coaching will be part of actually both strategies, as you'll hear. In the treat to avoid symptoms group, the medications focus on early treatment of flares, effective treatment of flares, diet and lifestyle education to minimize the number of flares that happen. But if someone in the treat to avoid symptoms arm is getting miserable because of recurrent attacks, they can switch over to allopurinol, although the focus is really more on slow increase of the dose of allopurinol if there's still flares, and less on the serum uric acid level. And if one is interested, this is our study website and also a QR code. But if you take a picture with your camera, you get a yellow pop-up. And if you tap that, you go to a questionnaire where you can express interest in the trial. Now, as we sit here right now, you heard about the study sites that are involved. And if people are interested in the trial and live in one of the areas where we have a site, it would be relatively straightforward to include you. There is a physical exam up front to see if they're tophi. If people have a heavy burden of tophi, they really need urate lowering therapy, so they're not candidates for the trial. And but we're working on a strategy to see if we could do all virtual recruitment, including lab work and physical exams closer to home for people who are not near one of the sites. So I realize there are probably people on this call from all over our great country. And if you're interested, I might suggest you send your name in and we can keep you posted on what's available in terms of joining the trial, even if you're not in the neighborhood of one of those 7 centers. And I think with that, I'll just ask Hyun, anything you would add that I've missed?
It was excellent, Michael. Just want to reiterate, the TRUST trial will provide a free gout care. Again, both arms are standard of care. The one from primary care, the other one rheumatology standard of care. Again, 2 years of standard of care free, including the medications, lab, everything else included, education, all those things. So free gout care, 2 years, excellent education. Just wanted to make it clear.
You know, you're right. And you reminded me that Gary described the trial he was in with an experimental medication that wasn't available.
Right.
There are no experimental medications here. These are tried and true medications that have been used for decades for gout care.
Right.
I'll also follow up on something Gary said as it's appropriate here, and that is patients often have questions about participating in a trial if they don't have insurance. You don't have to have insurance to participate in this trial. Again, people can get enrolled if they have those criteria that we just talked about. And then also something Gary said is you get, expert care, right? So these fantastically expert doctors in New York and Boston and Atlanta, they are really keeping close eyes on you. I like to call it VIP medicine, right? So, I mean, you're really getting excellent care, even if you don't have insurance. They're doing your labs and everything. So keep that in mind.
And actually, because coming into Boston and parking for the occasional visit that we require is not easy. Particularly these days, we're doing a lot of construction. We actually have a modest payment for visits when people have to come in person or even virtually. So there's a little incentive there. We don't want participating in the trial to become a financial burden for people.
Right.
I have a
parking as well.
Yeah, I was
Very
just going to
important
ask.
in Boston.
Yeah, I was thinking about, my journey took 16 years to receive a diagnosis. There's probably members that suspect they might have gout, and maybe they're in my situation that they don't have a diagnosis, an official diagnosis, but they see symptoms, right? And they suspect and possibly even have gout running in their family, but they're just not able to get that diagnosis. Is this something, this TRUST trial, would it provide an opportunity for someone to seek a diagnosis if they don't, or do they need to already be diagnosed with gout in order to
Well, a
try to
diagnosis of
participate?
gout is a criteria for participation, but we do have the rheumatologic societies have criteria for a gout diagnosis, which we can review with people over the phone and see where they are in that diagnostic journey.
Also, as Dr. Berry showed, the eligibility criteria, they have to meet American College of Rheumatology and European counterpart criteria for gout. So they have to meet that criteria. So we can more or less make a diagnosis by evaluating for participation for this trial. Yeah.
And I'll probably add that some people probably have the experience of being diagnosed with gout when they have an episode of arthritis, say in their knee, and they get some of the fluid aspirated, and under the microscope, gout crystals are seen, which is a definitive way of diagnosing gout. But you don't necessarily need that to be diagnosed with the criteria for gout for entry into the trial.
Wonderful. Well, thank you so much for providing so much information about the trial. For those who do want to apply, do they just visit the QR code? Is there a deadline? And do they need to be a U.S. citizen?
I don't see a reason to be a U.S. citizen. Again, the trial would pay for the expenses of the gout care. So we want to be eclectic. And, you know, the more diverse the population in the clinical trial, the more applicable it is to the broadest spectrum of patients possible. So you always want to not restrict the population you study as much as possible.
Fantastic. Speaking of a diverse population, if English is not somebody's first language, do you guys offer any in-language assistance?
We are doing that. And now we're focusing on Spanish language in particular, because in the sites we're recruiting, that's the most common next language, but we'll move on to develop study materials in other languages as we expand the trial. We've started relatively recently, and we're working on it. And as far as deadlines, no, I will be recruiting for this trial for the next couple of years, I think. And again, so if you take a picture, a little code will pop up. There's actually a form to fill out that where you can express your interest.
Awesome. And we can also maybe drop a link into the chat later, just so everybody has access to it.
Sure.
For our next question, I'm sure the audience would love to know, how is the safety of patients prioritized during these trials?
Well, as Chris and Gary both emphasized, making sure that we're not only studying potential benefits, but potential harms of any intervention is important. Now, again, we're not using experimental medications, but people report their symptoms, how they're doing. We can do that virtually a lot of the time. They also get regular blood tests to check their kidney function, to make sure there's no problem that would mean their medication approach needs to be changed. And these trials actually have an independent data safety monitoring board where we report anything we find during the trial, so that we've got, if you will, an independent assessment of the safety of the trial. It's not just us. So multiple layers of protection.
Wonderful. Thank you for that. And then this question, I will open it up to everybody. Oftentimes, I think patients may have misconceptions about clinical trials. Everyone here has done a great job to shed some more light on that, but I'd like to open this question up to the floor. What misconceptions would you like to address?
Well, I think that I'll just chime in. You know, I definitely feel patients worry and concern, particularly when experimental therapy is being tested, but strategy as well. They're like, they'll use the word like guinea pig around here, right? And I go, no, you're going to be watched and scrutinized very much more than just going to see a doctor at an outpatient visit when you start a new medication. And so I want to highlight that whatever clinical trial we're talking about, as Dr. Berry just shared, man, there is an independent board of everybody watching, you know, and really reassuring safety. I mean, that is just massively important for these clinical trials, strategy or medicine. So I want to definitely reinforce that and minimize that worry and concern.
Maybe
Yeah,
one more. Oh, go ahead, Gary, please.
Oh, thank you. I was just thinking about, you know, gout patients and how much of a warrior spirit we have. right? And when I say that, I mean that we're tough. You know, people who live with gout, they're tough. We're tough. We tend to handle pain well, and because of that, I think we have the you know, we just possibly will downplay the severity of our condition and what is going on. And it's not surprising that I would hear people within our group, our Gout Support Group of America, that will say, Gary, I've only had 2 attacks this year, right? And as you know, again, I'm not a physician, and correct me if I'm wrong, but 2 or more is typically, you might be, maybe hovering in the chronic gout stage, right? So we tend to downplay. I've only
Mm.
had a couple of attacks. Well, my attack, last month only lasted 2 weeks. I'm good. I was able to walk around with my crutches, and so I'm okay, right? Like, so the mentality of people within the gout community is unbreakable, but I think we need to allow grace to come into our community, right?
Right.
And
Thank you for that.
we need to be able to say it's okay. If you're suffering, it's okay. It's okay to say, man, this is really painful. And maybe it's the way that I've been living with gout isn't the best way. It's okay, right? And maybe you don't have the solution. Maybe your loved ones, though they love you very much, they don't have the best solution. This is a great opportunity to really pick yourself up out of that and then move over and allow just a whole group of experts to be around you. Like, one of the biggest things that I learned from you, Chris, when I first met you, is you encouraged me to be a student of gout, right? When I was first diagnosed, and I said, yeah, that makes a whole lot of sense, right? I need to be an expert with the condition that I am now blessed to live with for the rest of my life.
Right.
I need to know, right? So
Give
give
I'll
yourself
put it,
grace.
there's a fancy name for what Gary's talking about, and we call it equipoise. And that means we're looking for people who are not sure what their best strategy for managing gout is, and they'd want to join a trial to learn more, both for themselves and for other people who have to face this diagnosis down the line. People shouldn't enter a trial if they're hoping they get one treatment or the other, because in fact, for these treatments, you can talk to your doctor and get either one if you're sure you know what you want. But a lot of people aren't sure, and a lot of doctors aren't sure what the best way to go for an individual patient is. So that equipoise is being willing to join a trial and get either therapy and seeing how things work out with careful monitoring.
Wonderful. Thank
I'll,
you so
I'll
much.
throw one more in there in that regard.
Please.
When I'm doing clinical trials, Gary was in one where you had to do that IV therapy, but I've been involved in others where we're comparing one pill to another or one pill to a placebo. And when I offer patients what that I consider very good candidates for the clinical trial, sometimes people think to themselves, "Oh, I'm not that sick. I mean, I don't need to be in like a trial or something. I mean, I just got, gout. And as Gary said, it only happened a couple of times a year. And plus, one of those was my fault because the Cowboys were losing and I just drank too much and all this kind of stuff." and I hear this all the time. They want to blame themselves. And that's the wrong way to go here, guys. Because if you're having periodic attacks, 1 or 2 a year, or 1 or 2 every here and there, and stuff like that, and you want to claim all of that, there's other things going on that are outside your control, right? And so you do need help. Actually, I don't want anybody who's listening in or looking at our blog later or something like that thinking, I'm not sick enough for this. If you're having gout attacks, you're sick enough and you need an answer. Okay. So I'll just put that card down. It ain't the Cowboys. Okay.
To that end, particularly this trial is looking for if you experienced one flare last year, then you are eligible. not like many flares, but if you're just one flare, that's it, that you would qualify. Yeah, so again, it happens to be we are looking at people cared under primary care doctors rather than rheumatologists, so milder cases, perhaps. That's the really primary target population. If you're already well cared by rheumatologists, you don't belong here. But they are a small minority group, as Dr. Berry presented. Only 10% or less are cared by rheumatologist specialists. Like it or not, that's our situation in the US. So we are really talking about 90% of gout patients in the US.
Fantastic.
for that.
Thank you for that. Gary, Chris, this one is for you guys. So you have both seen many clinical trials. What makes this trial unique versus other trials you have seen?
I mean, to me, that's an easy one. Here, we're not studying different medicines and versus placebo or anything. These are two completely different strategies. And that makes it extra special because each doctor that has a strategy applies that to bunches of patients. And so ultimately, if we come out of this trial learning that one strategy is clearly better than another, or one strategy is clearly better than another in a certain population, that needs to be employed regularly. Okay, so this is a very important trial in that regard that I've never been a part of.
Yeah, it's so important. I look at this trial and I think back. It's like the battle that has been going on for so long, right? Do I proactively treat gout or do I reactively manage gout? Right? It's something that, Chris, we at GSGA have been talking about from the very beginning.
Right.
And oftentimes it comes down to just the anecdotal, experiences of people. It's fascinating that we're at this point now in history where we have the ability now to with time, we're going to be able to collect enough data to really make a definitive conclusion.
Yeah,
And
it's exciting.
for me, yes. And for me, yes, of course. I've told Hoy and Michael, I said, I have a bias, but I don't want to I don't want to lead by the bias. I want data. I want scientific proof. Either way, because whichever way, I know it's going to be the best way. So as a gout patient, and I believe, the gout community, we are looking for the best way to manage gout effectively. So why? There's only one purpose. And that is we can stop living in fear and that we can regain quality of life and avoid gout attacks. That's the bottom line. So get me there through this way, get me there through that way. I don't care. As long as we have data to support it, I'm good to go. So it's so important, right?
On that note, we do have a question. And one of the questions is, what is life like once gout is under control?
Gary can tell, I guess.
That's Gary's.
My goodness. I think you just set me up for that one, Stephanie. I mean,
well, let me amplify that a little bit, Gary, because you said something that I don't think people who don't have gout think of very much. Speak to fear for a moment, because that's something that, we talk about gout all the time. We talk about pain, right? But fear, expand on that so our listeners can hear.
Right. So when you are living with unmanaged gout, it really, the one main factor that drives and dominates your life is really fear. It's fear of the unknown. It's fear, hey, when I go on this vacation or I'm planning something, will I be able to finish it? Right? Will I be able to experience it to the fullest? It's fear going to a restaurant with your family and looking at all the marvelous choices, of eating pho or eating brisket or that hamburger, and then you're probably the only one in the group thinking, "Oh my God, like,
Yeah.
what's gonna happen to me? Should I roll the dice or
Mm.
what?" Right? And no one else. They're just living life, and you're secretly battling this voice inside of
Wow.
you. It's
That's
that
horrendous.
fear. It's
Yeah.
that fear, and take it to an extreme. It runs every day, all your thoughts. It eats away at you. So imagine if you can remove that. I'm not saying that there's a cure for gout. We all know there is not. But what if I can tell you that there's a way to live with this condition with gout and remove that fear? And in fact, with gout, you can walk into a restaurant and look at all the marvelous choices and be able to pick what you want without fear. Wow. What if I can say that you can live with gout, have this condition, and go be active? Go out there and live it up. Live your life how you want to be. You're out there at the gym. Maybe you're in a martial arts, right? And you're wanting to go out there and spar. Maybe you're wanting to go walk on the beach or you want to go swimming, but you're afraid that maybe it's going to activate your gout. If you can remove that fear,
Yeah, it's
what
massive.
kind of freedom that is, and a lot of people take that for granted, but the people in the gout community, you know what I'm talking about. And if we can figure out how to best manage gout, then we can remove that fear, right? And we're all on the same page then, by the way.
Right.
Then the argument stops, right?
Right.
Because we have data
Yeah,
to
the data.
support it. So,
Wonderful. Well, thank you so much for sharing that. And speaking of fear, I'm sure some people who are interested in participating in the trial might be afraid of the time commitment. Do Dr. Berry, Dr. Choi, could one of you maybe talk about the time commitment involved with this trial for patients?
Sure. Well, participating in a clinical trial does take some time. We've tried to minimize that time. There are, over the course of the 2-year follow-ups, as it stands right now, 3 in-person visits. The rest of the visits can be done virtually. And we have, there are blood draws. Sometimes we need to get those because they're research labs at that face-to-face visit, but others can be done in the community if you've got a lab near you to make that more convenient. We do have someone reach out to you either electronically or by phone every 2 weeks just to check, have you had a flare? Because remember, our main outcome is the flare count in both groups. So we need to do that accurately, and we need to do it the same in both groups. So while there is a time commitment, we've worked hard to try to minimize that. And again, we're trying to go to an all virtual approach if we can, without anyone being able to criticize the fact that we did that when we come up with our answers at the end.
Michael,
Kevin,
let
would you
me
add
follow up
anything?
on that. Yeah, I'd like to follow up with that, with a question on that. Are there any financial support or options for those that might need assistance to get to the site at this point?
Well, we do pay a stipend if you have to come in for the visit, and if there's parking, which there often is around academic medical centers.
We cover
pay for the parking.
transportation. We cover transportation as well.
Okay.
Right.
Mm,
Yeah.
Good deal.
Great.
Yeah. Yeah.
Wonderful. I have another audience question unrelated to the trial, but I think we have the perfect group to answer this. How have most people detected gout? Or what are the ways people have detected gout?
That's again primarily is pretty characteristic, and the patient themselves learn about it, read about it, and that's one way to do it. And eventually, to medical attention, primary care doctor is still the provider that picks up the diagnosis most. most often. Again, cared 90% by primary care doctors. And there are other non-rheumatologist doctors as well, but the rheumatologists pick them up about 10% or less.
Right, there's some variability. Some people have a classic presentation with recurrent attacks of inflammatory arthritis, mostly in the lower extremity, but not entirely. And if that pattern happens, and there are relatively few things that can do that. There are some things we think about Lyme disease in our neck of the woods, but it's relatively easy to exclude those other causes. Sometimes with a confusing case, as I mentioned before, we actually may need to, during the attack, take a little sample of the joint fluid. I've had done myself. It's not too bad, and that's in some ways the definitive way to make a diagnosis of gout. Uric acid is also a factor, so we look for an elevated uric acid. But one warning is that during an acute attack of gout, the uric acid may take a dip. So you ideally want to recheck the uric acid after the flare has gone away and been successfully treated. So it's done in different ways. And Gary told his story about how long it took him to be diagnosed. Usually it's not that hard, but having a high index of suspicion for doctors and clinicians in primary care, as well as for patients, if they've got these recurrent inflammatory attacks in the joint, gout is really kind of at the top of the list of what it might be.
Yeah, it's
Fantastic.
common. I'll take 30 seconds too, Stephanie, just for our listeners who are just individual people wondering how did you get here? So Gary's story is not too unusual, but I envision myself, you wake up one morning and you don't know you've got gout, you don't know anything. You just wake up one morning and your toe, midfoot, ankle, or knee, this is the usual, lower extremity. What the hell? What the heck, I guess, depending on where you live, is going on down here? I mean, my God, this just is gigantically painful. This is not an uncommon scenario. You'll gimp your way to the medicine chest, get out some Aleve, Advil, Motrin, or whatever is left over from the last time you had a tooth extraction. And guess what? If it doesn't cool off, this thing is so darn bad. Yes, as Dr. Berry points out, you might visit your primary, but lots of people say, I don't got time for that. I'm going to urgent care, ER, podiatry, somebody who can look at me today, the sooner the better. Okay. And so it's pain that drives people into their primary, their ER, their urgent care, or something like that. And hopefully, as to Dr. Berry's point, there's only a few things that are likely to hit you this fast and this hard that we need to think of, meaning we, the medical community. And so hopefully we arrive at this diagnosis pretty quick, right? To get you on the right course of therapy, either one strategy or the other, as we're talking about here with the study, right? To bring this thing down. But to Gary's point, if you show up at an urgent care, ER, podiatry, primary care, or wherever, and it's not typical, you might bounce around from one shop to another, meaning one clinical place to another, but for a long while before you ever arrive at a diagnosis. And then to Dr. Choi's point, you might be sitting at home reading, trying to understand why the heck does this thing keep coming back and I can't get a hold of it. So that's kind of the way this thing goes if you're an individual patient, suffering and struggling with how do I get diagnosed with gout?
Thank you for that. We will bring it back to last question about the clinical trial, and then we will turn it over for closing remarks. The last question is, if patients are interested in participating in clinical trials, be it this one or another one, how would they start the search, right? And how would they know if the trial is right for them?
Well, I'll jump in again. Go ahead, please.
No, I mean, for this trial, obviously, we're trying to keep people informed about how to reach out to us and let us know you're interested. A medical center near you will often have a website that has a list of clinical trials that are recruiting patients in your area if you wanted to find out what trials in general are going, are running and might be recruiting patients in your area. So that's another good way to find out what's going on at your local medical centers.
Yeah. And piggybacking onto that, the GSGA website has a list
Mm.
of centers that are doing gout research, because this is not the only study, right? There's other things going on all the time. Modern medicine is trying to advance constantly and answer different questions. So you could, check our website, and I think we might have a link to, is it the NIH or the something, where there's kind of .gov that has a list.
Yeah.
I think we have
Clinical trials.
Yeah, thank you, sir.
Yeah,
Yep,
yeah. Clinicaltrials.gov. Yeah.
yep, thank you.
Wonderful. And we will also drop in the link for the GSGA website. So if anybody wanted to take a look of some of the blogs or, where to start the journey, we welcome you to do that. And then thank you again so much, everybody, for participating. Can I turn it to each one of you to give closing remarks? Any last words?
Well, I'm going to just thank Dr. Berry and Dr. Choi for visiting us today and sharing the details of this clinical trial that's exquisitely important, that we're all anxious actually to skip to recruitment and give us the answer because we really want to know. And it sounds like we're going to have to wait a while, but thank you guys so much for joining us, because we want to help any way we can. And if there's a possibility for, smaller centers or places like I live, that where we can participate, if it could all be done remotely. I mean, there's a lot of gout in Texas, not just because the football isn't very good here. It's just because it's common.
We've got the Patriots, Chris. So
Yeah, thank you. They used to be awesome. So
Yeah, it used to be.
So I'll just say thank you so much for inviting us and letting your audience hear about the trial. Again, we've given you a way to reach out if you're interested. And if there's interest down the line, we can give a progress report. It is unfortunate that you have to do that recruiting and following patients to get to the answer. So that'll take a while, but we can give you a progress report on how we're
we'd
doing.
love that.
Mm-hmm.
Yeah, we'd love that.
Absolutely.
Absolutely. Yeah, I'd like to second my thanks as well. It has been a pleasure, and would love to have another opportunity perhaps to share progress report, as well as maybe another sharing of the trial introduction again.
I'd love that. I'm sure the 16,000 patients on our support group are all going to be waiting anxiously.
Yeah. Perhaps a different audience next time, perhaps, but we'll see. See it go.
Yeah.
Yeah.
You got anything, Gary, you want to wrap up with?
I would just like to say again, thank you to Dr. Choi and Dr. Berry. It's been an honor, a privilege.
Agreed.
Chris and I are so excited about this trust trial. Again, it's long time coming, right? And for the gout community, it is, I can't emphasize how important it is. And for me, to our community, for me to you guys, if you think that you are living with gout and you would like to find out more, take your phone out right now, like I did. You saw me earlier tonight. Take out your phone, take a picture of this QR code right now so that you can have that information. And then see if you can participate. We're talking about the greatest of care, right? And it's all research for good. I mean, it doesn't get any better than that, honestly. Right. So with that, I will say thank you for your time.
Well, thank you again, everybody. Dr. Berry, Dr. Parker, Gary, Dr. Choi. We know you have an incredibly busy schedule, and so wish everybody a wonderful evening. And for those of us who were not able to join today, we will make sure to share this video with everybody. So thank you and have a good night.
Outstanding. Thank you, Stephanie.
Thank you all. Good night.
Thank you.
Bye-bye.
Good night.
Bye now.